Hello, everyone. Welcome to another installment of The Way It Is. And Luke Andelfato here with RE/MAX Service First Realty. And a very timely and very important guest back with us, the first repeat guest. And so you do have the dubious honor. Dr. Evans, with the infectious disease specialist with Queen's University, is back. And timely because, well, jeepers, how the heck did we get here? I mean, we went from Cinderella to the Wicked Witch. How did that happen?
Yeah, that's a question I get asked a lot by many people. I mean, the issue here is that it certainly was seen over 100 years ago with Spanish flu that communities that did very well during sort of the early waves of the pandemic, oftentimes when subsequent waves arise, there's an increase and they get hit a little harder. It's a combination probably of a couple of things. The most important one is that when we look at what's happening with COVID-19 is that, you know, our vaccination rate here in Kingston and Southeast Ontario is at or even a little higher than what you see in some of the major cities like the GTA. But what the major urban centers got early on in the pandemic was a lot of people who were infected. And if you'll recall, you know, during first, second, and third wave, the Toronto area, Brampton, Peel, Hamilton, and those places really had a large number of cases. So the end result is by the time this fourth wave arrived, they had their vaccine protection already there against Delta. Plus, they had a fairly large percentage of the population, maybe 10% or so, that had already had COVID infection and might not have been immunized. So they had a combination of both prior infection and immunized people that was a higher percentage, say close to about the high 80s to 90% of the population. Here in Kingston, we had so few infections during the first and second waves that what essentially happened is that we were totally now reliant on immunization. And we did well here. We had, you know, of the total population, it was about 78%. Eligible, yeah, it's even higher. But if you look at the total population of Kingston and KFLA, for instance. So result of which is that we didn't have that extra sort of 10% of previous infections within the population. And so what we ended up with was actually an immunization or an immunity rate of only about 80%. And that was about maybe 10% less than it was in other areas. And those susceptible people are the ones that drove that sudden surge of cases in the fourth wave that here in Kingston that we saw in November. So that's how that happened. The other thing is that we know in communities that did very, very well, and as you said, we were the Cinderella sort of things during the first, second, and third waves, is there's a kind of I'm trying to find a better word than complacency, but it's sort of an idea that, oh, well, we're doing really great here. You know, this isn't something that we've had to worry about in Kingston. So, you know, why don't we try and get things back to normal? Let's do a lot more socializing. Of course, restaurants are open, bars, nightclubs, gyms, all the places and, you know, we don't have capacity limits up until recently, of course, capacity limits in all those areas. So that little part of behavior also helped to contribute to that big rise in cases in November, which were all basically Delta cases. And now, of course, maybe we're going to discuss in a few minutes, what's happened is that riding the crest of that wave on a surfboard was Omicron. And now we're facing that whole problem of being somewhat unfortunate in that Omicron has hit us rather early.
And so, yeah, I mean, I've got several questions. So Omicron, so Delta, because, you know, I heard earlier on when the wave was hitting that it was primarily Delta, and it threw me a bit because I thought, well, like, were we just late to the party with Delta? But obviously these strains, once they come into play, they become this dominant variant. So Delta essentially was there as the dominant variant, right? I mean, the original COVID protein, I guess, probably doesn't even exist because it's all Delta now, right? And so now, am I saying that right, or is that?
No. So what we refer to the original strain as the ancestral strain, the one that sort of started it all off, and the ancestral strain really dominated through until the late part of 2020 when Alpha emerged, and the Alpha variant was one that was first described in the UK, and Alpha very quickly outcompeted the ancestral strain. And what existed at the time, which was an early strain that doesn't have a Greek letter, it's called D614G. It had to do with the mutation description. And that's actually what we saw here in Eastern Ontario first. And we did whole genome sequencing and published a paper on the introduction here in the southeast part of Ontario was this D614G. But essentially, it got replaced by alpha. And that happened very quickly, sort of through the late part, December 2020 into the early part of 2021. And then alpha dominated for a long time until about the late spring, when Delta had emerged. And then Delta very quickly just dominated as of about May to June. It just swept Alpha away. And then Delta became the dominant variant that existed right through into November. And it was in early November that we had the start of the big increase in the fourth wave, which was much bigger here in the southeast part of Ontario than it was in the province in general. And so that was all Delta driven. And then now, of course, what's happening and will likely dominate things by January is going to be Omicron. So Omicron is able to outcompete Delta. So ancestral strain started, Alpha outcompeted the ancestral strain, Delta outcompeted Alpha. And then Omicron is going to outcompete Delta ultimately to become the dominant strain. And then perhaps, hopefully not, but perhaps Omicron ultimately in a year or so might be dominated by another variant that comes out that's even more potentially transmissible.
So why is Omicron that much more contagious or infectious, I guess, than
well, we don't know
Delta?
yet, but it's really fascinating that we know why Alpha beat out the ancestral strain. And I'll try not to make this too complex, but essentially what Alpha did is it tricked your cells when it infected them into not launching an early attack against it, which was mediated by interferon. Interferon's an antiviral substance that all humans make. And so Alpha, by just crippling that system for about the first 12 hours of infection, was able to really establish the infection much, much better. And that's what knocked the ancestral strain out. So along comes Delta, and Delta used a completely different mechanism. What it did is it allowed the fusion of membranes, which is a really important step in the viral infection of a cell, to occur at a much faster rate than it did with Alpha. And it panned out that mechanism was even better at amplifying the early stage of infection in someone than Alpha did, and that's why Alpha disappeared. We don't know what it is about Omicron yet, but if it follows the same script, it's going to be a funny cellular mechanism that has caused the increased transmissibility. In other words, Omicron's infecting humans and doing it in a way that outcompetes this rapid fusion that we saw with Delta. And I think that's really important because a lot of people are imagining it's the mode of transmission that's changed. In other words, I guess the thing that I've heard people say is, well, maybe Omicron's more airborne. I always think the airborne is a little bit like pregnant. You're either pregnant or you're not. So you're either airborne or you're not, and it's not more airborne than something else. So it's probably a cellular mechanism because the modes of transmission of these viruses continue to be multimodal. It's mostly related to close proximity. If you're close to someone who's infected, there's a bigger opportunity to encounter a sufficient dose of the virus in an infectious form to be infected. There's probably some, but not a lot of transmission through a contaminated surface. We know that maybe accounts to 5 or 10%. And what I would call as an IPAC person, a long-range airborne transmission doesn't actually occur very commonly either. It's probably accounts for no more than about 10% of infections. So it's that close proximity exposure to these respiratory particles that are in and around and contaminating the surface near someone that results in that transmission. But this whole domination of one variant over another is almost always related to a virological aspect of infection and not to the mode of transmission.
Okay. So, and see, and the immunization part of it has almost been, I certainly listen. I'm a believer in vaccination. I'm a believer in immunization. So, an end of story. I won't get into a debate about that. But it almost seems like our vaccination, like you said, we're in the situation we're in now because we had to rely solely on immunization. Now, our vaccination, it seems to be a bit of Achilles' heel now because now we're getting into these asymptomatic situations now, right? Where you or I, as double vaccinated people, come into contact with Omicron and we can be walking around with these symptoms and not display, or you know what I'm saying? Be positive and not display any symptoms. So,
well, the other trick that Omicron threw at us was that it mutated a lot, and it mutated in the area around the spike protein, which is very important in how we get protection through immunization. Because what we do is we make antibodies and we make an immune reaction from other cells that attack that spike protein. So when Omicron got all these mutations, what it started to show was some erosion of the immunity that we had from either being immunized or having had the infection before. It's not complete. One of the things, and this is what you're commenting on, Luke, is that if you are full vaccinated at the moment, what we call full vaccination is 2 doses, it's probably going to be 3 doses. And I've got 3 doses now, but I'm a doctor who works in a hospital. So, and the issue there is that you're still protected from serious infection, even with 2 doses, even better with 3 doses. But you're right, it tends to then therefore make it a bit of a mild disease. And one of the challenges we've had into the late fall is that people probably were developing symptoms. It was probably COVID, but it was so mild because they were fully vaccinated that they sort of said, it's probably just a regular cold, I'll go to work. And that's when we were starting to see transmission events occurring, because people were going to work when they would normally stay home before they were vaccinated. And we said, look, if you're sick. So we had to get back into messaging to tell people, look, if you've got mild symptoms, don't go to work, don't go to school, stay home, get tested if it continues on for, a 24 to 48 hour period to make sure it's not COVID. But that's the other problem with Omicron, is that this erosion has also left us with a little bit more susceptibility. And what we know from data that's come out of South Africa, for instance, and even what we're seeing here, is that people who've been previously infected with COVID or had COVID, they're getting this Omicron variant COVID again, which really from our past sort of understanding would have been really uncommon, sort of within about 6 months of a previous infection. And we're also seeing that double vaccination, 2 shots, is still providing this great protection against severe infection, but less protection against actually getting infected. When you had 2 shots before with Delta or Alpha, you had about anywhere from 70 to 85% reduction in actually even being infected. That's dropped off a fair bit now. It's about 30% with Omicron. So you can now get infected and, as you say, have mild symptoms or no symptoms, and that's getting to make it tricky. And that's another advantage Omicron has. If it infects you, but it doesn't make you too sick because you've been vaccinated, gives it an opportunity. I don't want to personify a virus, but gives it the opportunity to sort of spread around to other people. And you're doing it really quite innocently, especially if you have absolutely no symptoms whatsoever. So those are the tricky parts of it. But what we do know is if you get 3 shots, if you get a 3rd dose following those 2 doses you've already had, then your prevention of infection rises again, and it goes back up to about 70%. So for Alpha and Delta, you needed two doses of the mRNA vaccines. For Omicron, it looks like you need 3 to get the same effect on preventing infection and likely preventing transmission. But 2 shots or 3 shots, you've got very, very good protection against severe illness, severe outcomes, like having to go into hospital, ICU, or dying.
Right. Well, I went on yesterday morning as soon as you could, and I'm booked for my booster on the 21st, I think. So
good for you. No, that's great.
So segueing into what is the best testing protocol now? I mean, rapid tests are out there, PCR tests, but it certainly can't be. It's problematic to tell everybody to go get a PCR test every 72 hours or something like that, right? I mean, that's just not feasible, right? So are rapid tests, yes, no? Are they worth it? They
definitely have a role to play. I'm on the science table here in Ontario. We just did a brief actually that was released last week on the whole issue of rapid testing. Rapid testing definitely has a role, and it's very important because if you test positive on a rapid test, it's pretty conclusive, and you don't really need to do a PCR test to confirm that. A positive rapid antigen test has what we call very high specificity. The positive predicted value, the value of a positive test, is enormously high. It's a little tricky when you get into high prevalence areas like we are now, because then a negative test is a little less reliable. In other words, there's a higher percentage of negative tests that could be falsely negative. But certainly it helps if you can do testing in people who are at risk, because if they're positive, you keep them out, you've identified them, you can isolate them, and you can prevent further ongoing transmission. And even though the value of a negative test is a little less, it's still pretty good when you look at it, that it, generally speaking, in an asymptomatic person who hasn't had any contact with anybody with COVID who has a negative test, you can pretty well rely on it as being most of the time truthful, probably in the neighborhood of about 85 to 90%. So that also maybe reassures you. But that's the little tricky part, because the negative test doesn't have quite the same value as a positive test with the rapid test. But when we deploy them out a lot, when we get testing tons and tons of people, it actually becomes a very good strategy, because although you're not going to capture everybody, you're going to capture some, and you may capture enough that adds into that layer of protection, right? So everything's about layers of protection. There's not one thing that works and to the exclusion of anything else. Rapid tests have a role? Absolutely. Do immunizations have a role? Absolutely. Big one. Does washing your hands, staying physically distant, and masking? Yes, all absolutely. Are improvements in ventilation and filtration likely to be useful? Yeah, probably. One of the problems with ventilation and filtration is we don't have direct evidence that it does anything, but most of us believe that it likely does. And that's just based on the fact that we know it has an impact on respiratory particles. So that's the one that still needs that connection with the direct evidence. There's no doubt these aerosol scientists can tell us lots about how to clear the air of respiratory particles. The problem is we don't know how much of a dose is in those particles, and is there a sufficient enough reduction that it reduces that risk. But they can certainly tell us that if you open up all your windows, and I've been hearing advice from people saying, open up your windows in the middle of winter at -20 to ventilate your house, which strikes me as a little bit of a funny thing to say to a Canadian. But that sort of advice might be pushing it a little bit in terms of understanding what that role is. So we're still looking for what is the direct reduction in transmission that happens through ventilation, filtration, et cetera. And then, of course, we get into this whole mask issue and should you wear an N95 mask versus a medical mask? And I'll tell you right now that the evidence that we are seeing, as much as it bothers people who are big proponents of N95s, who claim that if everyone wore N95, the pandemic would be over. I don't know what planet they live on, but it's not my planet. The fact of the matter is that any mask, but particularly medical masks, and of course an N95 equivalent respirator, is going to reduce the amount of virus that you inhale sufficiently low that it's probably preventing infection. And I don't think there's a super magic part of an N95 over a medical mask, other than in the hospital setting where we're taking care of COVID patients and we have procedures and things that happen that could increase the risk. And of course, at that point, we do suggest to healthcare workers that the preferred mask, if you're taking care of somebody who has COVID, is an N95 mask.
All right. And I certainly don't want to put you on a political hot seat either, but I know, given that you're on the science table, my kids live in Halifax. Nova Scotia's been perennially doing well through the entire pandemic. And I'm a CBC junkie, and so listening to one of the reports the other day, these rapid tests should be something that are distributed to the general population. And in fact, the analogy that they used was the analogy was condoms. Let's give everybody condoms so that they can practice safe sex. Let's give everybody rapid antigen tests so that they can at least keep testing themselves to keep safer, or add that layer, as you said, of protection in terms of monitoring the disease.
Yeah, there's no question that tests have a role. I guess one of the things that I've been really sort of noticing as we've moved into this, really entering now into the second or third year of the pandemic, is people are lining up around particular issues. And that's why I just emphasized there are so many layers to all the things that we can do to prevent infection. There's no question. My colleague, Lisa Barrett, who's an ID doc in Halifax, has been a big proponent of testing. She's been a real advocate for it. I think it's been one of the key strategies they've used in Nova Scotia, and they're continuing to use. And yes, they dole them out free to anybody who wants them. But I think the expression is, don't put all of your eggs in one basket, if I remember right. Yep. And so what we've seen with Nova Scotia and New Brunswick too, who've done well during the early part of the pandemic, is now in this fourth wave, they're getting hit because you cannot rely on one strategy. I know that they're not relying on one strategy, but they certainly have invested a lot in testing. It worked for them during the early waves of the pandemic and may continue to work for them during this fourth wave that's starting to drive up numbers out in the Maritimes as well as here in southeastern Ontario. But I think the key is that we have to do all of this stuff. We have to continue masking. We need public health measures. I mean, there was a very good report that came out a few weeks ago of what's called a meta-analysis where they collected all the trials on masking, hand washing, and physical distancing. And what was fascinating is hand washing reduced the risk of transmission by 50%. So,
wow.
I've seen a lot of people on social media saying, well, why is everybody talking about hand washing? This is airborne. Well, no, hand washing works. So if hand washing works, it tells you it's not just airborne. It's other modes of transmission, which includes your hands as a potential a vector of transmitting it. So again, just going back to that whole thing, we've got to concentrate on all these measures. Testing is important. Testing should be used appropriately. I admire what they've done in Nova Scotia and everything else, but even with testing like they've been doing, they're getting hit with this fourth wave. So you've got to maintain all of these measures all together. And like I said, don't put all your eggs in one basket.
So I'm just going to go back to something you touched on earlier with the fact now that those that have had COVID are not, because there was the chatter before about herd immunity, and once you had the virus, then you'd built up antibodies. So obviously Omicron has thrown all of that out the window. So herd immunity isn't something then now that can be relied upon either then, can it?
Yeah. So coronavirus immunity is tricky. So when you talk about herd immunity, the classic one that's talked about is measles. But it pans out measles is a pretty, I don't want to say this to measles because it will insult them, but they're a pretty dumb virus. It's only got one real variant that's ever existed. We've had a live attenuated vaccine strain that has worked well for now almost 60 years. It was really rolled out in about 1964. And so there hasn't been much change to measles that allows it to evade that kind of immunity that we have. And so when people talk about herd immunity, they talk about everybody being vaccinated against measles. Then there's old guys like me who actually had measles when I was a little kid, because I was born just outside the range where I could get the measles vaccine. But once you've had measles once, that immunity appears to be lifelong, especially if you had natural measles. If you had vaccine-induced immunity to measles, we now know you need about 2 or 3 shots, but they can be spaced out over a long period of time, sort of one at age 1 and another one when you're 12, and then perhaps another one when you're a young adult. But that's about it for measles. Yeah, and so you can achieve herd immunity and control it well. Coronaviruses and SARS-CoV-2 as a coronavirus, they're a bit trickier. It pans out, and we've known this about the human coronaviruses for a while, is that you are exposed to them oftentimes early in your life. So typical coronavirus colds, common colds, happen in childhood up to about age 10. And there's a whole bunch of different viruses. They go by great names like 229E and OC43 and HKU1. But what happens, we know with those, is that once you get them, you are actually immune from catching that virus again, but that only lasts for about a year or 2. And then you can actually get infected with that same coronavirus. What we do know, though, is that the immunity from getting really sick from those coronaviruses, that actually goes on for a lot longer, and probably upwards of maybe a decade or 2. So this coronavirus is behaving like other coronaviruses. It's able to change itself a bit, but the immunity that our immune system makes towards these viruses is not lifelong like it is for measles. It's much shorter. And sterilizing immunity, the immunity from getting infection again, is probably only maybe a year or 2. Protective immunity, fortunately, is probably maybe 10 to 20 years in duration. And so that's why we talk a lot about this sort of endemicity that might happen with SARS-CoV-2, that eventually it adapts itself, doesn't kill off its host, because a really dumb virus kills off the host that it wants to infect. And then if you do that, you got nowhere to live. It's like blowing up your solar system and there's no planets left.
Yeah.
So the coronaviruses have really adapted this, and we're starting to see that SARS-CoV-2 is acting a lot like regular coronaviruses. It infects you. It probably can reinfect you again in a year or two. But it's possible that initial infection protects you from all the most serious consequences. And part of this age skew that we've seen, that the older you are, the more likely you are to have serious, deadly outcomes from COVID compared to younger children. And that is a reflection of what we also see with human coronaviruses, that decades and decades afterwards, when you're in your 70s and 80s, you're now 70, 80 years from those coronavirus infections you had when you were a kid. And that's probably why that sort of protective immunity has dropped off and makes you more susceptible to being more seriously ill.
Well, and I had this written down and I skipped right over it, but why are we seeing now that it's predominantly this younger demographic or it's not, I'll give you a glib answer. It actually has to do with the fact that if you're a virus, the group that you really want to get into are young adults. And that's because young adults socialize. I don't know how old you are. I know that I'm old, probably older than you for sure. The fact of the matter is we maximally socialize from our late teens into about our third, fourth decade. And after that, our socialization drops off. If you look at an index of socialization, it diminishes. The number of people you run into, the kinds of things you do. I don't go to dance floors anymore and spend the whole night dancing and drinking. But if, when I was 18 or 19, did I do that a little bit more? Yeah, a little bit more for sure. And so what we've seen with a highly transmissible variant like this, with the relaxation of public health measures, is once it gets into that younger demographic, it has a lot more opportunity to spread. The networks of transmission amongst young adults are huge. The networks of transmission in 60 and 70-year-olds, not so much so. So last 2 points are almost a two-pronged point, or I guess they'll dovetail to one another, but from an infectious disease perspective, what is the way out, barring full global vaccination, which I still don't think is the way out? So, because, understanding that Omicron seems to have originated from South Africa, and then all of a sudden someone got on a plane or something got, someone traveled somewhere, and next thing you know, here we are, right? So,
immunization is a key strategy to speeding it up. If you want to think about it, if we didn't have vaccine, and we were just relying on, like the Spanish flu did back in 1918, 1919, there would be a lot of people getting infected. There'd be a lot of deaths. The Spanish flu was thought to have killed as much as 60 million people around the world when it emerged after World War I. What does that process do over a decade or so? Is that it allows for the evolution of endemicity. The survivors now have antibodies against that Spanish flu strain. They've survived. The virus diminishes within the population so that newborn people are less exposed to it, or at least when they're exposed to it, it may be somewhat attenuated. So what immunizations are doing for COVID-19 is they're speeding up that process. In Spanish flu, we looked at probably about a decade for that endemicity to occur. And for most people now, by the time the 1930s and 40s rolled around, most people were immune, had been exposed to H1N1 virus, which is what Spanish flu was at the time, and had some reasonable immunity to it. We still had people dying, but it was very small numbers, not the major pandemic. With the coronavirus, if we didn't do anything and if we didn't have immunizations, we would be looking at this kind of impacting the planet for probably anywhere up to 10 or even 15 years. And ultimately, we would have seen a large population immunity emerging that was protecting people. We were seeing perhaps a diminishment in death. It would have killed a lot of people. We now know the Americans, 1 in 100 elderly Americans were killed by COVID-19 in the last 2 years. So that's what would have happened. And what we can do with vaccination, and especially by rolling out vaccinations, we can speed that process up. We can make it all happen within about 3 or 4 years, maybe 5 years, and then really have this virus under control and allow it to evolve into another human coronavirus that exist like the other ones with the fancy names I told you with all the numbers. So that's what immunization is doing. I think it allows us to speed up the process of this virus becoming endemic and becoming less of a hazard to everyone. But in the meantime, it will have killed off a lot of people. And it's really, its impact has been most profoundly seen in seniors. And again, this age skew is so an impressive part of what SARS-CoV-2 has done. It's allowed, in general, younger populations to survive even without immunization. But without immunization, older individuals would have been really and truly decimated in the context of the word from Latin, which means to kill 1 in 10 people. That's what immunizations have really done for us. So it has been a very useful thing. And I think it'll be part and parcel of whenever we face these pandemics in the future, is that sort of technique of moving the evolution of this process along so it doesn't take decades and decades, but rather just a few years, and facilitated by protecting people with immunization.
Well, I mean, I have to say the one of the positive byproducts of this pandemic has been the ability for these pharmaceutical companies, governments to produce these vaccines in such a protracted period of time, right? I mean, because when COVID first started, we were hearing the stories about how it would take 10 years to get a vaccine from inception to shot in the arm. And here they did it in less than 10 months or whatever. Yeah. And here we are now with a booster. And this goes back to, I'm sure we did this in the first time we recorded, but this is going to be an ongoing booster that we're going to need to get every year, just like a regular immunization shot, is it not?
Yeah, it may very well be, without question, or at least every couple of years or so, depending on how long that durability of that protection from infection lasts. I mean, the other cool part about not just this rapid development, you're very right, it was about 10 months really from the start of the pandemic until we had vaccine. If you think the pandemic started in March, we had the vaccines by December. And typically when you develop a vaccine in the old-fashioned way for something, it's about a 10 or 15 year process. But the other really cool thing is the platforms developed, like the mRNA vaccines. Even now, the manufacturers are working on a Omicron specific variant one, because all they need is the genetic sequence to make a new mRNA template. And that might be the effect of the booster. Like that booster may be part and parcel of it as a new variant were to emerge. Hopefully this is going to slow down as we immunize more and more of the world. And that's such a critical point right now to sort of get the total number of infections down so that we can not allow another variant to emerge. But, variant specific ones, as they begin to dominate, may become part of the picture. And we can do that now. We can do that really fast with the mRNA vaccines. They're telling us essentially it's about 6 to 8 weeks. And you can come up with a whole new vaccine that's now an Omicron vaccine versus a D614G vaccine, which is kind of what we're dealing with right now. So that's the other real incredibly impressive technological feat of the 21st century, is these new platforms.
Well, that's awesome to hear, and I'll hang on to that optimistic outlook for sure. And I know you're a very busy man, and I'm really appreciative of your time. So I guess in closing, given we're obviously Christmas is literally around the corner, people want to get together. Give us your best advice for anyone this Christmas and going through what we're going through here in Kingston.
Yeah, big challenge. People have made plans now for probably a number of months in anticipation this was going to be a better Christmas than last year, a better holiday period than last year. I think we're stuck into really getting ourselves back into that mindset of Christmas in 2020 as we face, the Christmas 2021. And I recognize that some people have made, huge plans, maybe expended a lot of money to go traveling. And now it looks like, you can't reverse that. So be careful if you're doing that. If you can change your plans though, and just keep that socialization back at the level that you sort of had last year, just as the vaccines were rolling out, we were facing the holidays last year, and keep those contacts as small as you can. That will really impair the virus's ability to get around and transmit to people. And I would say, especially right now here in the Southeast, we're still facing this Delta wave. which we had kind of hoped and thought would start to drop off right about now. But Omicron, as we've just been talking about, kind of surged right up on the back. It rode the crest of the wave of Delta into our region. And so I think we're looking at this for the next few weeks. It's definitely going to happen over the holiday period and into the doldrums of January. The one shining light that's really interesting, and I just was looking at some data, is that big wave that happened in South Africa with the original identification of Omicron, that's already starting to plateau. So that's actually a very rapid plateau. That's only, about 3 or 4 weeks from that big, huge jump to the plateau and now diminishing. So maybe this wave, I'll throw out a wild speculation that maybe this wave is not going to be quite as long and as big as the ones that we saw before, but that still waits to be seen. South Africa is a very different country from Canada. In many, many ways in terms of its society, in terms of immunizations and everything else. But I think people need to be just, again, it's hard to ask for, to be patient. I don't think this is the end of the world. There's been a lot of that kind of talk in this last little while. And I think we just need to do all the right things. And those include, as we're just talking about now, watch your socialization over the holidays, hang out with the people do all the right things. If it goes down to -20, if you're going to open the windows, don't do it for too long. But
unless you unless you want your heating bills to go through the roof,
exactly. And I do believe that heating costs have gone up. So just watch that and do all the good things that you've been doing. Wash your hands, practice physical distancing if you're out and out and about and doing some shopping, whatever else. Wear a mask, I'm maybe a big proponent of medical masks over cloth masks. That's about the only way I get that. If you have a lot of money to spend and you have a splurge, you can go buy yourself a KN95 or an N95. But really, all you're doing is spending a lot more money on a mask that pretty well does what a medical mask does. I think out there in the big bad world, if you work at the hospital, it's okay. We supply those types of respirators for you. If you're a nurse or a doctor or RT or whatever else.
Well, listen, I want to thank you again. Thank you so much. You stay safe. You have a great Christmas yourself, and hopefully you get some much deserved time off. And because I know I hear you on the CBC all the time. I know you've got a busy, not only professional agenda, but all these other speaking engagements and everything else. So we appreciate your time and thank you so much. And hopefully, if we do this a third time, you have to promise me this is going to be a good one, right? We're going to have one where this is in the rearview mirror, and we're going to be having all those conversations.
Yeah, right? That'd be a great one to do. And thank you very much. I appreciate it and the opportunity to come on and chat with you. And I hope you have yourself a good holiday too. Merry Christmas and all that stuff.
All right. Thanks, Doctor.
All right.
Take care.
All right.